All of the light and energy related ones are interesting. The problem is FDA doesn't demand of them the degree of testing they do of a drug. So those expensive studies that you have to do for benzoyl peroxide and erythromycin never get done for the laser. And I've not seen many studies with rigor enough to say that, yes, I believe this works. So that's something that, it's promising, but at the same time, I don't know how to evaluate it. I believe they do work. I just really want some data. If I'm going to tell a patient you should spend $4,000 and 5 visits on this thing, I won't feel comfortable unless I know that I can look them in the eye and say, you're not wasting your money. I think there will one day be a biologic that hits the magic button for acne. Don't know what it'll be, and that could be a real game changer. You could, I suppose, have an antibody that kills oil glands, which would work like Accutane with none of the side effects. We've taken the level of understanding a few notches into rosacea. Before we kind of said, I don't know, and mumbled about stuff. And now we know that the innate immune system's involved, and at least in some of the patients, Demodex is the trigger. And we've got a pretty good drug in ivermectin to treat it. But we still need better data and more understanding for why people get it and why they don't. My personal guess is that the mast cell is at the heart of it. It is the nexus between the immune system and the nervous system. And we know nerves are involved in rosacea because people get blushy. They are wired differently than non-rosacea patients. They blush in response to all kinds of things. And that seems to be the thing that pre-exists before the pimples and the rhinophyma and all of that. So it seems like it's the core of rosacea, and we're still sniffing around that one. Well, I'd like to see a magic bullet. I want to see an Accutane for rosacea, but sebaceous gland's not the problem, so Accutane won't work. And I think getting at the mast cell's centrality might be the target for that magic bullet. I'm less certain of that than why some people get acne. The rosacea patients are predisposed. They often have a family history. They get hints of rosacea-like stuff, such as styes in the eye as a kid. And I think it's their neurologic wiring that sets everything up that develops later. Acne is a different beast. Acne's big problem is response to skin bacteria, mainly Cutibacterium acnes. And years ago, we and others showed that people with bad acne had a heightened immune response to the bug, had more antibodies, had more cellular immunity, which is just what you have when the immune response is the problem. So I think there's an inherited hypersensitivity to Propionibacterium acnes. And that explains why bad acne runs in families. We all the time see kids who are put on Accutane and dad with pockmarked face. So the family link is clear, even if the studies are a little squishy. And I think that link is the same as the link in allergic disease, where people inherit allergic tendencies. You can inherit hypersensitivity to P. acnes too. There's a lot of microbiome studies going on, showing that there are strains that tend to be in inflammatory acne and others that tend to be in non-acne patients. But that distribution is hardly absolute. There's plenty of people with bad acne who don't have one of the bad strains, and plenty of people with no acne who have one of the bad strains. And I think we'll find one day that it is not a hot strain that causes acne, that those strains that are associated with the disease are ones that are tougher, and they can withstand all of the inflammation that goes on in acne. Maybe they handle oxidative stress better, I don't know. But I think they'll be found to be the survivors, but not uniquely pathogenic.